Okay, so next, we're going to talk about arthritis of the hand and the wrist. Again, another topic where volumes of textbooks cover this topic. We're going to cover it in 10 to 20 minutes. So, arthritis of the hand and the wrist. The most important thing to keep in mind, we're going to keep this simple. We're going to simplify it by just talking about arthritis at the base of the thumb, because every walking, talking human being gets that. We're going to talk about osteoarthritis within the hand, because that's also something that affects every walking, talking human being. And we're going to talk in very brief summation about rheumatoid arthritis, because rheumatoid arthritis is something that governed about half of hand surgery practices 20 to 30 years ago, but now with DMARDs, we're talking about something that I operate on once a month, if that. Thumb basilar joint arthritis. So thumb carpometacarpal articulation is one of the earliest sites of osteoarthritis in the entire body. It affects women 10 to 15 times more commonly than it affects men, because women do the hard work. Men get this typically from post-traumatic arthritis if we see it in men. And x-rays oftentimes, in multiple studies we've seen, x-rays oftentimes don't correlate with symptoms. And this is really important because patients may have severe osteoarthritis on an x-ray, but may have no symptoms. And so thumb carpometacarpal articulation. If you look at where your thumb runs in relation to your wrist, where your thumb meets your hand, that's your metacarpal phalangeal articulation. We're talking about the joint just ahead of that. So where your thumb metacarpal meets your wrist bones, that's your thumb CMC joint. At this joint, you've got motion. You've got abduction, which is where your thumb comes up from a flat table, adduction when it moves back to the flat table, extension when it moves out, flexion when it moves in, when you flex your thumb and try to bring it across, and opposition when you literally bring it across your palm towards your pinky. With pinch, compressive forces at the thumb CMC can be up to 12 times what they are at the tip. This is why one reason why this joint wears out very quickly. The other reason is, and I don't ride horses, but every textbook describes this as an English saddle joint, whatever that is. But basically, you're talking about two joint surfaces that don't really conform with one another. So the elbow, the hip, the shoulder. The hip is like a ball and socket. The shoulder is like the bottom of a teacup and saucer. Those have conformity. This has almost none. And so when the ligaments of the thumb wear out, you've got bone rubbing against bone, and those 12 times tip forces, they come into play very quickly. So it's not atypical to have a patient in their third, fourth, fifth decade where they have arthritis almost nowhere else on an x-ray. They very, very commonly may have arthritis at the base of their thumb. And so the other reason why, in addition to those compressive forces, we get arthritis at the base of the thumb is because the beak ligament, there's one ligament that really stabilizes this joint more than anything else, and it's a ligament that runs from the palmar tubercle, the trapezium, to that beak, the ulnar aspect and proximal aspect of the thumb metacarpal. When that ligament runs out, so does the stability of the CMC joint. Very important to eliminate other possible causes for pain at this area, which include scaphoid fractures, tendinitis, ligament tears. How do we diagnose this? Almost entirely via x-ray, report of the patient historically, but really by a CMC grind test. So what do? We take the thumb and we try to shove the metacarpal into the trapezium, for lack of a better description. You literally grip onto the base of the metacarpal with one hand, you grip onto the distal, onto the trapezium with the other, and you try to shove them together with rotation. And if the patient reports pain with that, if you combine that with their reported symptoms, in addition to x-ray findings, you've got a positive CMC grind test. The other thing that we diagnose this via is x-rays. So Eaton-Littler classification, most widely radiographic classification system for some thumb CMC arthritis. We're talking about 4 stages. Stage 1 is widening of this joint space where the metacarpal is now moving away from the trapezium. We think this is because of synovitis or fluid, a lot of postulated causes. But if you've got not really osteophyte formation, but a patient that has thumb CMC reported symptoms, we're thinking that this is stage 1 basilar joint arthritis. Stage 2, this joint is closed down but we don't have significant osteophyte formation. This is stage 2 of the Eaton-Littler classification. Stage 3, you've now got greater than 2 millimeter osteophyte formation, cyst formation, sclerosis, but it's only at the thumb CMC articulation. That's stage 3 disease. And stage 4, the entire trapezium is covered in arthritis. So not only the thumb CMC articulation, but also the articulation of the trapezium with the scaphoid. We usually call this pan-trapezial changes, and this has a direct impact on how we might manage folks with thumb carpal metacarpal arthritis. Now, really important, this patient who shows up with clear advanced thumb CMC arthritis, they may not have symptoms. They may have just thumb CMC arthritis on an x-ray, but they may report nothing. What governs how we manage them is symptoms plus their x-ray findings and their clinical exam findings. But if they've got advanced thumb CMC arthritis, typically what we see is flexion. The thumb metacarpal typically goes into flexion as this beak ligament wears out and this thumb CMC joint wears out. You could even see subluxation or dislocation of this joint. That's not traumatically. That's from wear and chronic subluxation or instability of the joint. You can see web space contracture. So now the thumb, where you typically have space between the thumb and the index finger, that no longer exists at rest. Non-operative treatment. So the rule with folks with thumb basilar joint arthritis is we usually manage them non-operatively initially. How do we do that? I usually get patients a hand-based thumb spica splint from occupational therapy, and you tell the patient to use that at nighttime. It usually works great. Non-steroidal anti-inflammatories. They're not tremendously effective or haven't been shown to be in clinical literature, but you can give that patient the option. Activity modification, I'm not a big fan of this, but a lot of clinical literature will point in that direction. I like to keep patients supple and active. And lastly, injection with corticosteroids. So if these three things fail, consideration for injection with corticosteroids, you can do that either with or without guidance. I prefer to do it with guidance because it ensures that the injection goes into the articulation, and also patients usually report less pain because you're cheating a little bit. You're basically putting the needle right into the joint. Operative treatment. So indications for management of this operatively. The patient has failed all of the things we just mentioned non-operatively. They have advanced arthritis or arthritis on their radiographs, and now they also have symptoms that have been refractory to all the symptoms we just talked about. So thumb basilar joint arthritis, how are we going to manage that? This is for completion's sake. If a patient has stage 1 disease, they have CMC pain, and they've got a CMC joint that doesn't show those osteophytes, we talk about doing an extension osteotomy, where we take a wedge of bone out of the proximal metacarpal, we extend the metacarpal, and voila, the metacarpal is aligned differently, and the load through the carpal metacarpal articulation is going to be different. This is a 1 in 100 type of situation. Most patients with stage 1 disease don't present, or if they present, they respond to non-operative management. So even though this is an operation that exists, it's not one that we often utilize. Simple trapeziectomy. So in full disclosure, this is not what I do for this condition, but if you've got CMC arthritis, you can simply take the trapezium out and you can get equivalent clinical results to all the other described procedures. It's a simple, safe, effective procedure. The problem that exists with simple trapeziectomy is that you can have patients with residual pain, and the most concerning thing as a hand surgeon is you can have patients that have residual instability and or subsidence. So literally, the thumb metacarpal, this is a thumb metacarpal that's making its way down to the scaphoid because there's nothing in the space where the trapezium came out. So even though this is an option, it's not the one that I personally deploy, and it's not the most commonly used procedure for this. Hematoma distraction arthroplasty, another perfectly acceptable way to manage this. What do? You take the trapezium out, you pull a little on the metacarpal, and you insert a pin or a wire that's going to keep this space theoretically open because the wire is slightly keeping this joint distracted. There's no ligament reconstruction, there's no tendon in position, and again, what's the problem with this? One is you can have subsidence, and also you can have problems associated with this pin that's sitting in there for 6 weeks. Perfectly acceptable way to manage this. You get equivalent results to the other procedures, but it's not the procedure that most of us use for this, at least in the clinical literature, because again, you may end up needing to do something else, and you would need to do that through a scar bed if that happened. Implant arthroplasty, again, another potential option. These look really cool, right? They look really cool until they dislocate. So the problem with implant arthroplasty, even though this is a perfectly acceptable way to manage this, there is very little long-term data to support the use of implant arthroplasty, and moreover, similar to the implants we use for MCP, for the wrist, and for the IP joints, those implants wear out quickly. And when they do, then you have a bigger problem on your hand, because now, again, you're operating through a scar bed, and you may have eliminated other surgical options that otherwise may present the patient with decent, good to excellent results most of the time. How do most of us attend to this problem in the clinical literature? We attend to it with something called a carpometacarpal arthroplasty with ligament reconstruction and tendon interposition, LRTI. We do a trapeziectomy, and we do a ligament reconstruction and tendon interposition using a tendon to supplant where the trapezium came out and to stabilize that joint. So what do? We take the trapezium out, and then the FCR, that tendon that runs in your wrist and inserts at the base of the index finger metacarpal, when the trapezium comes out, we're looking directly at this tendon in the surgical bed. We can take either half that tendon and weave it through the bottom of the thumb metacarpal and take the rest of the tendon and anchovy it and fill it in as a space filler into where the trapezium came out. That's one way to do this. This is not the way I do it, but it's a perfectly acceptable way to do this. The alternative is to use the entire FCR. This is how I prefer to do this procedure. You take the entire FCR, release it within the wrist or forearm. It gives you a bigger muscle belly to work with. You take the tendon and weave it through the base of the metacarpal, and you take the rest of the tendon, the other half of the tendon, and weave it like an anchovy very nicely into the space where the trapezium came out. LRTI is indicated for patients with stage 2 through 4 arthritis, most common procedure we use for thumb basal joint arthritis. You can use other tendons for this. Outcomes. So expect you still get subsidence with LRTI, but you just don't get it historically to the same extent you get it with those other procedures we talked about previously. You actually get improved grip and pin strength. In multiple clinical studies, this is borne out. And so the patient who presents with pain, even though you're taking a bone out of the wrist and you're providing them theoretically with less structure, they actually can function better. And most clinical series, again, report greater than 95% good to excellent results with this procedure. It's one of the best and most predictable procedures in all of hand and wrist surgery. Complications, stiffness, paresthesias, pain, swelling. Things happen after the surgery. It takes time to recover from this. But usually by the 3-month mark, most patients are back to doing almost everything they were doing before and are doing more because they can do things without the pain they had previously. Salvage procedure, so you can use other tendons to supplant the FCR if that initial surgical procedure did not work. Considerations, so sometimes when you've got arthritis at the base of the thumb, you get arthritis at the MCP joint, where the thumb metacarpal meets your proximal phalanx, where the thumb literally meets the hand. If the patient has hyperextension at that joint because the arthritis is so advanced, you may need to do something else to stabilize this joint. What do? If it's hyperextended 20 to 40 degrees, we talk to patients about doing an MCP capsulodesis. We literally tighten the capsule. Or if it's greater than 40 degrees of hyperextension, we literally talk about fusing that joint at the same time as that other surgical procedure at the base of the thumb. What's the reason for that? Well, if you tend to the base of the thumb, and now they're pain-free in that area, but their thumb is literally pointed straight to the ceiling because you didn't stabilize this joint, you've done nothing for the patient. You've effectively eliminated the pain, but you haven't given them a functional outcome. That's why we attend to the MCP joint when it's indicated. What do we do a fusion for? So a thumb CMC fusion is really reserved for young, active males, heavy and intensive laborers who have stage 2 to 3 disease, so they don't have arthritis at the trapezioscaphoid joint, but they've only got arthritis at where the thumb metacarpal meets the trapezium. What do? We fuse them there. This preserves grip strength, but you've got to make sure the patient understands that they're going to be fused with their thumb In palmar abduction and pronation, their thumb's literally going to be sticking up a bit. And the other thing they have to be aware of is that in about 10 to 15% of those patients, you have to be concerned about non-union. Fusion may not take, just like fusions anywhere else in the body, and they may need more surgery to go attend to this later. But it's certainly an option for your young, active laborers. Other forms of arthritis that we see in the hand and the wrist. So carpometacarpal bosses. Index finger metacarpal, where it runs into your carpal bones, you may have a hardened mass. At the dorsal aspect of the hand, x-rays are diagnostic, so you see this big hump. And usually we deal with this only if symptoms arise with it. Many patients get carpal metacarpal bosses. Few of them need surgery. What is the surgical treatment for this? Usually if the patient has an extensor tendon subluxation, so their index finger tendon is now moving back and forth when they flex and when they extend and flex the index finger over the boss. If that happens, we shave the boss down in surgery. So boss pre-op, boss post-op. Heberden's nodes. All of your primary care patients have these. Very, very few of them need surgery for it. Heberden's nodes are those nodules at the DIP joints that arise with osteoarthritis. We get really advanced arthritis, and then we get these big, big nodules or nodes at the last joints. How do we treat this? We only treat it really with a DIP fusions in patients that are extremely painful and or are having a deformity that dictates that they need this. I see many patients with Heberden's nodes. Very few of them need an operation. Complications that arise, hardware prominence and non-union. Mucus cysts is a topic that's going to come up in all likelihood later. These are degenerative cysts that result from osteoarthritis at the last joint. You can aspirate these, you can excise them. This is what a typical mucus cyst looks like. It arises because you got too much fluid in a joint that's too small for it to take on. And again, this is a mucus cyst diagrammatically. This is a large one. Bouchard's nodes, so osteoarthritis at the PIP joints. You can get nodes that are caused by PIP spur formation. How do we tend to these? NSAIDs, heat and ice, OT. Very infrequently does this come to needing a surgery, either an arthroplasty or a fusion. STT arthritis. This is arthritis within the wrist, wear and tear, where the scaphoid, trapezoid, and trapezium meet. How do we deal with this? We typically deal with it with a fusion, and that's only when patients fail conservative management. Piezotriquetral arthritis. So this is where the pisiform, that round node of a bone that sits on the ulnar aspect of your wrist, where that bone forms arthritis with the triquetrum just underneath that. We talk about doing non-operative treatment modalities such as injections. When injections don't work, we talk about simply excising the pisiform. You don't need it. Very quickly, rheumatoid arthritis. Why is this going to be the very quick portion of the talk? Because I'm running out of time, A, and B, because very infrequently does this come to needing an operation these days. DMARDs are really remarkable at converting this disease from something that needs surgery to something that almost never needs an operation. The most common form of inflammatory arthritis, it affects 3% of all women, 1% of all men, genetic predisposition. Rheumatoid arthritis, you can see hand involvement, most significantly with rheumatoid nodules. We almost never need to take these out. Usually I leave these alone because they typically recur and cause even bigger problems when you go attend to them. So only if there's a concern for the underlying pathology do we go excise these. And these are usually found not affecting the DIP joint, but they can. What else do we see with rheumatoid arthritis? We usually see or can see a positive rheumatoid factor when we see rheumatoid nodules. In addition, we can see MCP deformity. So you see ulnar drift. All of us have seen this in our patients. Basically, you get proliferative synovitis that causes stretch on the MCP capsule, and it causes predilection for ulnar drift at the MCP joint. This is caused by and can be concomitant with wrist deformity, flexor and extensor problems, and it's typically the RA deformity that we see in the metacarpals. It's usually because of, it usually comes from proximal problems. So it's not that they just have ulnar drift. It's usually that you have radial deviation in the metacarpals because you've got a problem at the wrist level. This is just for completion's sake. There are ways to manage RA, advanced RA, with implant arthroplasty, synovectomy, ligament releases. It usually doesn't come to it these days. Swan neck deformity, again, advanced swan neck deformity is DIP flexion and PIP hyperextension. You can treat this non-operatively with a splint, and most patients actually do pretty well with that, at least initially. You can consider doing synovectomies, DIP fusions, oblique retinacular ligament reconstructions. All of those are on the menu, but it usually doesn't come to that. Extensor tendon ruptures, we still see these in our rheumatoid arthritic patients. When we see them, we deal with this either with ligament repairs or more commonly with tendon transfers. So you can take the EIP tendon, extensor indus proprius tendon, and transfer it to the ulnar extensor tendons. These two guys, your ring finger and small finger extensor tendons, are usually the guys involved with extensor tendon ruptures in RA. Whew. Okay. Any questions at all? So you do if there's concomitant, it's a great question. So carpal tunnel syndrome and thumb basilar joint arthritis, they can travel together, oftentimes do, but they don't have to, and they're not related. And so, yes, your patient with thumb basilar joint arthritis may also have carpal tunnel syndrome, and you've got to examine the patient completely to figure that out, and you may need to do an EMG or diagnostic studies to prove that to yourself. But at the end of the day, you may not see thenar atrophy, but if you do, you have to have on your radar antenna has to go up. Oh, my patient with thumb basilar joint arthritis also has advanced carpal tunnel syndrome. When I go attend to their thumb basilar joint arthritis, I also better attend to their carpal tunnel syndrome. Any other questions at all? No, yeah, so nerves, vessels, tendons, they all pass in that path. And so, yes, the radial sensory nerve is always at risk. Yes, you've got to be cognizant of how you're going to approach the joint. Some people go direct lateral or dorsal. Some people go, that's my way to generally approach this. Sometimes you have a spur that blocks the entrance of the needle into the articulation that way, and you've got to go dorsal to volar to get into the CMC space. And so you always have to be aware of the nerves, vessels, and tendons in the path where your needle is passing. But at the end of the day, I tend to use fluoroscopy these days to guide, and also many of my patients have already undergone a thumb CMC injection, and they found it to be painful, but I try to convince them this is going to be a good way to postpone or potentially eliminate their symptoms altogether, and that may be one way to accomplish the task if they don't want to undergo the injection in the office. Any other questions at all? So ganglion cysts, mucus cysts specifically, are the ones that we typically see associated with arthritis at the DIP joint. Those are the guys that arise just within the proximal nail fold. If you see a mucus cyst, yes, you can aspirate it. Yes, you can just leave it alone and it has the potential to go away on its own. Yes, a mucus cyst could be mimicking some other mass that may be arising. So a mucus cyst may not be that you think is a mucus cyst, may not be that. It could be a giant cell tumor tendon sheath. It could be some other form of nodule. It could be a squamous cell carcinoma for all we know. But at the end of the day, if it's a classic mucus cyst, then you're typically going to approach that either by leaving it alone, aspirating it, or excising it in the operating room. Any other questions at all? All right. Happy Saturday.